today's session by Trending As A to Z series by Academia of Global Obstetrics and Gynecology. And today, discussion would be on episode S, which is sexual health and safe abortions. Before starting the session, we'll be starting with a small prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
And I would like to welcome our coordinators, Dr. Pradnya Supe Agrawal. She's an MBBS, MS Obstetrics and Gynecology. She's a consultant gynecologist, laparoscopic surgeon, Agrawal Heart and Women Clinic, Mumbai. I welcome you, ma'am. And I would like to welcome Dr. Munjal Pandya, MS OBGY, FICOG, Diploma in Minimal Invasive Surgery. He's an associate professor at Narendra Modi Medical College, Ahmedabad, Gujarat. I welcome you both. I hand over the session to the coordinators.
Good evening, everyone. We start with our first session. I would like to invite the chairpersons for our first session, Dr. Shyamal Seth. Yes.
I'll introduce Dr. Meera Agnihotri, madam.
Sure.
And yeah, so thank you so much. May I have our slide of our chief guest, Dr. Meera Agnihotri, madam. So we all know Meera Agnihotri, madam is a a great person, a very powerful person from north of India. She has been the professor, head of the Department of GSVM Medical College, Kanpur, chairperson, Ethics and Research, State Medical Council, and she has been advisor for Women's Health Cell, Ministry of Health, Government of India, represented FOXY and various organizations at international levels. And I had the opportunity just visit at that WWCon. I think that real great conference. It was such lovely, the Ganga and everything. I think it was just mind blowing the way they have organized. So Meera ji ke baat kya kehne, jitna bolo utna kam hai. So I know, and I'm so happy that she has come to this Trending Ask the Expert episode S series, which is focused on sexual health and safe abortions. And in our series from A to Z, we are having focused topics in obstetrics and gynecology. And today's episode, a real special one, which is going to focus on the intricate and the women's right issues. And I hand over now to Dr. Meera Agnihotri, madam, to address the audience.
At the outset, Komal, I'm really honored to be a part of this great meeting. And I really relish being with the company of not only Komal, but her husband also. So I congratulate the couple for being so active, so energetic, so academic and whatnot. I really enjoy both of you, your company, your academic endeavors and everything. I know that you are a convener, but coordinators, Pradnya Supe and Pandya. And guest of honor, Kiran, I can't see her if she is present. I convey my regards. She's not there, I believe. Yes. And the topic which are chosen by you, they are really very, very important. And sexual health is one topic which is really not very well talked everywhere, very widely talked, but it is just a tip of the iceberg which we keep on touching. But the more you give into the depth, you will find that obstetric gynecology ki har problem, it is starting with this capsule, with this small seed. So if we correct it, I believe we will be able to overcome very many things. Only a couple of days back, we have received a patient, one marriage, second marriage, third marriage, and ultimately suicide. So, I mean, it is not a very small thing which you can put in words and say that this is the sexual health. It's a very wide topic. It's a full book, I must say. And the more you read, more you learn, and more you admit it in your practice. So, Komal, it is a very important topic which you have done. And I think this committee will be working very hard this year also on this subject. Safe abortions. Since times immemorial, when abortion was not in practice, in our early days when we were students or postgraduate students, when abortion was not allowed, and after 72, it kept on going, and then 10 weeks, 12 weeks, 14 weeks, 16 weeks, and now they have come that if the pregnancy is incompatible with the life, you can go as long as 28 or 30 weeks, so that it is not causing mental health, mental trauma to the patient. So both the topics are very, very good. And I tell you, when I write down a DNB paper, I make it a principle that one of the subjects must be from it, because this is one subject which must be very thoroughly prepared by all the gynecologists. So, Komal, you have chosen a very good topic. I believe I could have been here for a longer time. I really wanted to join it. Maybe that I may join the second or third time, because I have to present in 2 meetings today. And one is already on, and another is after 5:30 onwards. So, मेरा मन तो नहीं है जाने का आप लोगों को छोड़ के, but I have to go. And इतने प्यारे प्यारे faces मेरे सामने, इतने सुंदर सुंदर नाम मेरे सामने, I just keep imagining and whatnot. Komal, your presence in our WWEdCon was very glorious, and I believe आप लोगों की प्रेजेंस से हम लोगों को बहुत गॉर्जियस फील हुआ. इट्स नॉट दैट बिकॉज ऑफ मी यू आर फीलिंग, बट आई ऑलवेज फील किसी मेहमान के आने से ही उसकी रौनक होती है. आप कितना भी बढ़िया सजा के रखें, unless there is somebody to love and admire it. So I really enjoy, and I am proud of it that persons like you and everybody was present over there. मेरी अटेंडेंस बहुत अच्छी थी. मुझे प्यार करने आए. Very rich in love, you know. So I once again thank Komal or wish you good luck in all spheres of the life, wherever and whatever endeavor you choose. We are with you on your right hand and always working, helping for you, and convey my love and regards and blessings to you and to your husband both. And we want that you must go at the highest point. Thank you very much. It's a very good topic. I will be joining in between once again if I get time, but I get my detached, and I just wanted to convey my regards to all the members who are present and who are going to join after some time, that it will be a wonderful meeting. My best of luck, my best wishes, love and everything for you. Thank you, Komal. Thank you very much. And I believe that Government of India is granting very many things in the next health issues apart from these things, and those who are practicing infertility, they may get new things very soon, because there are very many things which are in pipeline for us, and you may be getting a very good news very soon. Infertility especially thoda disappointed the, but maybe their disappointment is reverting very soon. I can't leak it because I am part of Government of India, but you are going to get good news very soon. Thank you very much. Once again, my best wishes and blessings to you.
Thank you so much, madam. Thank you for your lovely wishes. Your blessings really mean a very lot for all of us, actually. And the warm welcome which you always give at Kanpur, you know, the beat, the yatra part when we had come, or the conference, I feel so homely and so loved at the city. Thank you so much for being here, and thank you so much. And you're doing such a thing with the government. We are so proud about all your endeavors. And I know there are two Kirans in Kanpur. We have Kiran Sinha Madam, Kiran Pandey, but today we have Kiran Kurtkoti from Pune, and he is the next guest of honor. And he is the
I'm honored. I'm really honored to be a part of this dais. My regards to her also.
Yes, thank you, thank you. So we welcome our Vice President AMOX, Dr. Kiran Kurtkoti. He is the ex-chairperson of the MTP committee FOXY, of FOXY as well as AMOX, and has been the ex-joint secretary of Pune Society, a real hard-working, I think we have seen him working so meticulously, be it publications, be it in the conference, in the focus subject. You know,
it's okay, it's okay.
And I think he has the lovely knowledge which he always gives, and above all, he is a gem of a person. Welcome, Dr. Kiran Kurtkoti.
Thank you. Thank you, Komal.
Kiran, my regards to you.
Namaste, madam.
I'm feeling very happy to be a part of this dais with a person like you. So once again, I please pardon me for leaving. Kiran, I will be meeting you very soon.
Sure, madam. Sure. Respected Meera-ji, today's conveners, Komal, Niranjan, co-conveners, Pradnya and Munjal, and of course, all the other faculty members. Now, Komal, you have done a really good thing that you have selected two different topics. One is, of course, the sexual health, and the other is a topic close to everyone's heart, that is safe abortions. In fact, today evening also, I'll be taking a panel on safe abortion at a different webinar. So anyway, good that you have chosen these topics, and nice thing that you have got all the chairpersons of the MTP committee also. I myself being one of them, and I can see, I think Shyamal has joined. Shyamal is there. So a big hello to Shyam also. And what you are doing is a very good thing. The way in which you have taken your chairpersonship, we have seen that we are witness to the way in which you have conducted your tenure as the chairperson of the FOXY committee, and I'm sure that you should be elevated to the next higher position that you dream of in FOXY. So a very best luck to you, and my best wishes to this particular webinar also. And a big hello to everyone. I see Madan also. Madan is another aspiring person who is doing a very good work in the field of sexual health. So Madan, best wishes to you also. And all my close young brigade, Puneet, I also see Puneet is there. So Puneet, hello. And I also see Yukti ji. So a big hello to everyone, and my best wishes to all of you, and Komal, best wishes to you in particular. And my regards to Niranjan also. Thank you.
Thank you so much, Dr. Kiran sir, and I'm really honored that you are part of this webinar. I thank our chief guest and guest of honor for gracing this occasion. And now let's begin with our scientific subject. I'm really honored that Dr. Shyamal Seth is also there. As you said, he is the ex-chair of the MTP committee, and we also have Richa Sharma, who is the current chair, also joining, and I representing AMOX as the chair of MTP committee. So I'm really happy that we'll have a real great discussion, and Dr. Madan is always there, Dr. Nibha, Dr. Yukti, Manisha, I think everybody has joined, Dr. Usha. So we are looking forward for a great discussion, and I'll hand over to Pradnya to introduce the chairpersons. We will have slight change. I think Dr. Jeyarani joining a little late. So Dr. Puneet will begin the talk. You can introduce the chairpersons for the first talk. Dr. Shyamal Seth, Dr. Madan Kamble, whoever has joined.
Can I have the introductory slides, please, for session 1? Yes, so our first chairperson is Dr. Shyamal Seth. Sir is consultant practicing gynecologist from Kolkata, managing committee member and office bearer of the Bengal Obstetrics and Gynecological Society, and chairperson of MTP committee of FOXY. Welcome, sir. Our next chairperson is Dr. Madan Kamble. Sir is consultant OBGYN and aesthetic gynecologist, chairperson of the AMOX Aesthetic and Sexual Medicine Committee, and past secretary and president of the Akluj OBGYN Society. Welcome, sir. Madam is just joining. Our third chairperson is Dr. Savana Chongtham. She's an aesthetic gynecologist, director of Savana She Matters Women's Clinic, India. Welcome, madam. I now request our chairpersons to introduce our speaker, Dr. Punit Bhojani.
Uh, yeah, Dr. Shyamal Seth, sir can introduce the topic and talk about it, and then we can introduce the chairperson.
The speaker is, anyway, at the most outset, I want to thank Komal and my dear friend Niranjan for inviting me to allow me to participate as a chairperson in this program. It's a very nice topics. Probably I'll be able to go through few of the topics. Otherwise, because after that, maybe I will be busy in my clinic, but I will try to be online with the topics at least one in my 1 year, and the other year I'll be keeping engaged with my patients. So Dr.Punit Bhojani, the consultant obstetrician and gynecologist at the Bhojani Clinic, Matunga, and attached to Surya ASRCC Global Manisha Hospitals. Member Managing Council, MOGS winner of 15-year plus MOGS and AICOG awards, including Dr. Promila Bhatia Young Scientist Award 2011-2017, and has been given an award on Wonder Foxian Award. Founder of www.drmentors.com, providing video lecture for preparing students for MBBS and postgraduate entrance examinations. Author of books for PG entrance exams and MBBS examinations. Dr. Punit Bhojani, we are waiting to hear you, and he will be speaking on sexually transmitted infections commonly seen in OPD of our day-to-day gynae practices.
Yeah. Thank you, Chairperson, for your kind introduction. Will I get a permission to share my screen? Yeah. Is the screen visible to all of you?
Yes, yes.
Yeah, so at the outset, let me thank the conveners and the coordinators for the program. Dr. Komal Chavan, ma'am, thank you for the opportunity. And Dr. Niranjan Chavan, sir, thank you very much for having me over here. And my topic given to me is common STIs in clinical practice. So STDs are infection caused by bacteria, parasites, or viruses that spread through sexual contact, maybe genital, oral, or anal. They are a major public health concern. In fact, a WHO fact sheet says that more than 1 million STIs are added to the pool of infections, and it is estimated at 357 million new infections every year. And more than 500 million people are living with genital herpes infection at any point of time, along with HPV also. So the CDC, most among half of these are among young girls 15 to 24 years of age. Even in India, top 10 diseases for which adults seeking primary health care, and NACO has reported around 6% of adult population will be having STI. Now, why are we discussing about this? Because what are the common STIs? There are more than 20 different types of STIs available which can get transmitted: chlamydia, genital herpes, HSV, genital HPV infection, trichomoniasis, gonorrhea, syphilis. The list is endless. And I will be just focusing on the first 3 to 4, which we commonly see in our practice. So this is the entire list. The STDs could be classified as either an ulcerative disease, which is syphilis, herpes, LGV, chancroid, or it could be discharges. So it's called as sores and drips, and discharges would be gonorrhea, non-gonococcal vaginitis, and bacterial vaginosis. Why do we need to discuss this topic? Very important, because if not treated in time, it can lead to a lot of complications like acute pelvic pain, chronic pelvic pain, PID, which in turn would lead to infertility, ectopic pregnancy, vertical transmission, Fitzhugh-Curtis syndrome, even arthritis, and even certain cancers that all of us know, HPV-related cancers of the cervix with the HPV infection. So coming to chlamydia, the organism is Chlamydia trachomatis, one of the most commonly transmitted STD, easily spread because no symptoms. That's the main problem, that many of the STDs may not have. It's a silent disease. 75% of the infection in women and 50% in men have no symptoms. So if the symptoms do appear, it takes 1 to 3 weeks after transmission. Abnormal vaginal discharge, intermenstrual bleeding, dysmenorrhea, dyspareunia, dysuria, itching, burning. This is what it would typically look like. It could be associated with cervical erosion, whitish discharge, and there are other clinical syndromes that can be associated with chlamydia infection, like in men, conjunctivitis, urethritis, prostatitis, like what is called as Ritter's syndrome, long-term complication. Women, we can get urethritis, cervicitis, endometritis, salpingitis, Ritter's syndrome, and perihepatitis. This is the one of the pictures showing perihepatic adhesions, very common finding at the laparoscopy when we do for our patients who have got PID. This is the violent string adhesions which could be present in the perihepatic area. And reactive arthritis is a classic triad. Can't see, can't pee, can't climb a tree, because it's urethritis, conjunctivitis, and arthritis. Treatment, CDC recommends azithromycin 1 gram as the treatment, or doxycycline can be given 100 milligram twice a day for 7 days. Alternative regimens are also available in erythromycin ofloxacin. Coming to trichomonasis, again, one of the most common and most common curable STDs. T. vaginalis is the organism. It's a one-cell single protozoa, so it's a parasite. Incubation period would range from 4 to 28 days. A woman, the affected part could be vagina, vulva, cervix, urethra. And infected people without symptoms can still transmit the infection to others. So if I summarize this, it would be like foul smelling odor, itching, irritation, greenish yellow discharge, and painful sex. Most women with trichomonasis have no symptoms at first. And when the symptoms do come, yellow, greenish, frothy discharge, and redness, itching, burning, and pain during urination and sexual intercourse. So this is typically what we see as called as strawberry cervix. There are pinpoint hemorrhages on the cervix and the vagina, and also the greenish yellow discharge, what is seen in the patients. Diagnosis is more of a visual, you will be able to get it, but technically if you want to do wet mount microscopy, we'll see a flagellate model organism culture, and of course metronidazole is the drug of choice. 5 to 7 day courses available, as well as the start dose of 2 gram per oral. Coming to a very, very common infection, genital herpes. It's the most common cause of a genital ulcerative disease. Now, HSV1 and HSV2 are two organisms. HSV is generally above the waistline. So our oral and labial infection would be with HSV1. HSV2 is below the waistline. Positive organism, HSV for genital herpes is HSV2 more than HSV1. Transmission is through sexual contact or a close personal contact with a person shedding the virus. Vertical transmission can also lead to neonatal herpes. So herpes virus, it enters through the mucosal surface or abrasion on the skin. There is ballooning and reticular degeneration. It persists in the neural tissue and it can reactivate periodically, spontaneously, or in cases of trauma, stress, fever, or menstruation. I'll discuss the stressor factors for reactivation. So there can be multiple clinical scenarios. Primary infection. So primary infection occurs in people with no prior exposure. They are exposed to the virus for the first time. It's a severe episode. Pain, itching, vaginal discharge, tender lymphadenopathy. Systemic features may be there, fever, malaise, myalgia, and what we typically see is grouped vesicles on an erythematous base, which rupture soon to form painful erosions, which will have a polycyclic border, and lesion would persist for 1 to 3 weeks, but they would subside without a scar. So if you see, symptoms peak during the first 4 days of infection and abate in the next 7 to 10 days. Itching and local pain may precede the visible lesions by 1 to 2 days. Lesions erupt over 7 to 10 days, from vesicles, pustule to wet ulcers, and crusting and healing following over the next 10 days. Common sites in female: labia majora, labia minora, mons pubis, vaginal mucosa, cervix. So if you see this, here we can see it's a primary episode. You can see multiple grouped vesicles in the labial and the vulval area. And when they heal, when they rupture, this is what we get. This is a very painful condition, and also this is erythematous base and the lesion of the herpes. As you got the erosion. Recurrent episodes occurs in 90% of the patient. Risk factor is a prolonged duration of the primary attack. Duration, severity, and extent of the lesion are less than the primary infection. So lesions are limited, There will be healing will be quicker. Systemic symptoms are not prominent. And it has been suggested that herpes infection be considered in the differential diagnosis of any unexplained recurrent itching, burning, blistering erythema at the site below the waist. 1/3 of the patient will have 2 recurrences per year. 1/3 can have more than 6 recurrences per year. And emotional stress, menses, sexual intercourse have all been implicated in the risk factor for precipitating the recurrence. So here you can see the milder episode. This is a secondary or recurrence. You can see only a single lesion present over here in this picture. Common manifestations, as I already said, painful vesicular pustular lesions, ulcers. There could be some atypical presentation like itching, cervicitis, dysuria, painless ulcer, and sometimes even asymptomatic. Diagnosis, again, the visual perception helps us. It's a very clinical diagnosis, but still, if a smear can be taken, Zank smear, we get multinucleated giant cells. Culture is, of course, the gold standard. HSV DNA detection by PCR is available. Immunofluorescence is available. And of course, we can do the blood test demonstration of HSV 1 and 2, IgM, IgG antibody. Though they are not routinely done in the practice, they are just to give us the idea whether it's in patients of atypical infection, it can be done. Complications can happen, fungal infection, superated fungal infection, extragenital lesions, disseminated herpes, very rarely CNS complications. And if there's recurrent, it can lead to development of fusion of labia, urethral stricture, and even fetal transmission. The drugs available: acyclovir, valcyclovir, famiciclovir. Topical therapy not useful and should be discouraged. We have seen so many patients of this disease. Some have given a local acyclovir cream. It does not work. The treatment has to be oral. So topical therapy has got no role. So please don't prescribe the local cream, but give the oral medication. And it's a first episode. Acyclovir 400 milligram 3 times a day, 7 to 10 days. Valacyclovir 1000 twice a day for 7 to 10 days. And famciclovir available 253 times a day for 7 to 10 days. When there are recurrences, the treatment can be 400 TDS for 5 days based on the recurrences. Now, there is something called as suppressive therapy. The indication for this is if you have patients which have got more than 6 episodes a year, the recurrence of 6 episodes in a year, then these patients require suppressive therapy, which is long-term from 6 months to 2 years. Acyclovir 400 milligram twice a day can be used, or valcyclovir 500 QD daily. And what has been the safety? Absolutely very safe, for available up to some people, up to 20 years of constant use. No lab needs to be drawn and no drug holidays are required. And coming to genital herpes in pregnancy, complications could be a preterm delivery, neonatal herpes infection. If visible lesions are there at the time of labor, it is advisable to do C-section. Acyclovir can be used in pregnancy. It's FDA category B drug for primary and severe episodes of recurrent genital herpes. And suppressive therapy thrice daily for 36 weeks of from 36 weeks of gestation may reduce the herpes lesions at the time of delivery. So that also can be tried. If a patient is having recurrent episodes, you can prophylactically put them from 36 weeks onwards. Coming to genital warts, HPV, human papilloma virus infection is the causative organism. Incubation 3 to 8 months, and the common strains causing genital warts are 6 and 11 in approximately 90%. Oncogenic potential, we know that 6, 11, 42, 43 have got low oncogenic potential, and 16 and 18 have got high risk and their risk for development of cervical cancer, and 31, 33, 35 has got intermediate risk. So you can see we've got lots of various kinds. It is a very, I would say, polymorphic. It can present as either, I'll show you typical features as well as atypical warts also. So either we can have a condyloma acuminata, cauliflower shaped, occurs on a moist surface. As you can see over here, multiple in the labia, labial area, and in the perineal area also. This is one variety which is called as a typical condyloma acuminata. The second is also smooth papular warts, which are just 1 to 4 millimeter skin colored dome-shaped papules, which would be there. And these are the big keratogenic types of genital warts. So we need to know where these are. Visual inspection can give us the diagnosis, and this is also flat type of warts. So various manifestation, and this is one of our patients which we had applied the TCA as a treatment. You can see multiple warts externally as well as a post speculum examination. The cervix is studied with multiple genital warts which are there on the cervix also. As you can see with highlighted red color. So diagnosis, of course, post speculum examination. Pap smear goes without saying. We need to do Pap smear and liquid-based cytology, HPV typing done wherever available, and proctoscopy to look at the other areas of the warts. Serology for other STDs should be done, like HIV, hepatitis B, HCV, VDRL should be ruled out. What are the treatment options available? Imiquimod 5% cream can be applied, or 5-fluorofluoracil 5-FU can be applied. We have got good experience of applying trichloroacidic acid in our OPD or podophyllin weekly, and very rarely I also had to do electrosurgery for a patient who had a very extensive warts. One precaution we need to take, that the fumes which come out from the electrocautery, you need to have a good mask, because sometimes if you inhale the fumes, there is a risk to the physician of having developing this warts in the nasal and in the oropharyngeal area. So it's our as I would say professional hazard. So be very careful when you are using a electrosurgery or a CO2 laser excision. During pregnancy, podophyllin is contraindicated, so cryo or TCA is safe. It can spread during pregnancy because immunity is depressed. And if it's a very big warts, as I said, the giant warts which are blocking the introitus, then even a C-section may be required. And newborn is at the risk of developing juvenile onset recurrent respiratory papillomatosis. All of us know the vaccines are available to be given, recommended. The quadrivalent, bivalent, and of course now the nanovalent is available, which this and 2 doses, 3 was recommended, now even 2 is as good as 3 is what is said. Of course, last couple of slides on counseling the patient, that why need to protect themselves from STDs, because they can have drastic complications like malignancies. Recurrences is common after first 3 months of treatment, and barrier contraception is absolutely recommended. So coming to the ABC of preventing STDs, abstaining from sexual intercourse, being in a long-term monogamous relationship, and use of condoms consistently and correctly. So these are the 3 easy steps, like talk to the patient, test the patient, and treat the patient. April is the STD awareness month, and green ribbon is the symbol for it. And thank you very much for the patient listening, and thank you once again the conveners of the program, Komal Madam, for giving me the opportunity to be present over here. Thank you very much, and along with Dr. Niranjan Chavan. Thank you.
So much, Punit. I believe you have covered the subject very nicely, and these are the problems our patients do face, and we come across all these patients. The most important thing is that to give them a permanent cure. That's very difficult on most of the occasions until and unless we come to a perfect diagnosis and the exact line of treatment as you have recommended. This is very informative, I believe, for everybody who is listening to you. And I want some comments from the fellow chairpersons as well, if they want to. Few questions must be waiting for you in the chat box, I believe.
Congratulations, Dr. Punit. It was really a wonderful presentation.
Thank you.
You have focused the common STIs. Actually, we get in day-to-day practice, but we just ignore it, or we just refer to the dermatologist. But you have gathered so much information. It was really very helpful. Thank you, Komal ma'am, for giving me the opportunity.
Yes, thank you. Thank you so much. I know Dr. Madan was there for the Dr. Jeyarani's talk because it was very focused on the subject. But I know that sexually transmitted infections become really a problem, and we try to struggle with it because we want the patients to get treated. They don't come out and they can complicate things. I think Punit has very elaborately shown with the pictures, everything, how to diagnose and how the treatment should go in it. We at government setup, no, we have those kits. So we go as per the kits. So Punit, can you just elaborate on those kits, like how to go about and give those kits?
Yeah, so madam, there are color coded, that is called the syndromic approach. because we may not get a time to come to the exact diagnosis, and most of the infections would coexist together. So there are various kits available in the government setup, and you just have to, they are color coded, and depending on what the symptoms are, there are various kinds of kits available, color, black color, yellow color, green color, depending on whether it's a discharge or it's a genital ulcerative disease. And those kits are readily available, and we can use them for this. And as any STD would go, we should not forget partner treatment. It goes without saying, you need to treat both the partners at the same time. So color-coded kits are available in government setup. We in private practice don't have, I had taken a separate lecture on which I'm aware of about that, but we don't use it so frequently. But yes, in all our medical colleges and PHC level, these kits are available by NACO, and they would be various kits in red, white, green, and blue and black, depending on the patient's diagnosis. Even a nurse or a junior doctor can easily make the diagnosis. You don't have a specialist requirement. That's the advantage, and the diagnosis is not delayed, and you give it. Sometimes, yes, you will have a over treatment, drug resistance, but it is like treat all, and something is better than nothing. Kind like it's really effective in treating the patients.
So I know that it is very important because we need to treat them syndromically, and those kits are savior. So people should not hesitate whether to go back and turn back from even the government setup, because everything is available. What is the scenario, Dr. Madan? Do you all have there at your part all these kits available, access kits for treating sexually transmitted infections?
Actually, generally these are available in government setups, but we keep in our medical stores whatever we require. But I think we should know at least the basics, and which cases to be referred to the dermatologist, and which we can treat, and especially in pregnancy, we should know. We should have the basic knowledge and basic medicines available.
Yes, and pregnancy becomes a special condition wherein you can't give some of the drugs, like if there's a vaginal infection, you will not give your oconazole, fluconazole and everything. So we need to resort to local treatment, and we don't want any complications to happen. Punit, what about probiotics? Are there any role or any studies on probiotics?
Yes. So, madam, for bacterial vaginosis, which I didn't cover because it may not be considered as STD by some people do consider it. It's more of a flora imbalance in the flora. So when the good bacteria goes down, the daughterlands bacilli. So vaginal probiotics definitely have a role in management of bacterial vaginosis. They are available oral route as well as internal route. And specifically when we give it, like when we give a broad spectrum, like say suppose doxy has been given, then we are sure that along with the pathogen, the good bacteria would also get killed. So we have got patients who come up with recurrent bacterial infection, even fungal infection, and all these trichomoniasis, all these patients also probiotic has been said, and they have been studied to given for use.
Yes,
so
I think
yeah.
I really wanted to highlight that view because a lot of prescriptions come with a lot of probiotics and everything. So whether we should give. So definitely there is an effect, but we need to treat the primary cause. That is very, very important. Yeah, I think thank you so much, Punit. I think Pradnya can take over now.
Thank you, madam. Thank you.
Thank you.
Thank you, Dr. Komal, for inviting us
to
share this session, and before wishes to elections.
Yes, Dr. Shyamal, thank you so much. Coming from you is really, really very great, and thank you for all being with us.
Pleasure as well and privilege also.
Yes.
Thank you, Komal ma'am.
Thank you very much.
Thank
Best
you.
wishes
Thank you
from
so
me
much.
also. Best wishes.
So because we now move on to our panel discussion. Our topic for today's panel discussion is making abortion safe. I would like to introduce our moderators. Our first moderator is Dr. Richa Sharma. She's Professor OBGY, University College of Medical Sciences and GTP Hospital, Delhi. FOXCP MTP Committee Chairperson 2021 to 2024. National Corresponding Editor of Journal of Obstetrics and Gynec India from 2021 to 2024. And she has a lot of other awards to her credit as well. Welcome, madam. Our second moderator is Dr. Komal Chavan, ma'am. Madam is Medical Director at Chavan Maternity and Nursing Home, Senior Consultant and DNB Teacher at VN Desai Hospital, Chairperson of Foxy Medical Disorders in Pregnancy Committee 2019-22, and Chairperson of AMOX Family Welfare and MTP Committee 2022-2024. I request Madam to now start by introducing our panelists.
You can go ahead, introduce them. Call.
Okay, ma'am. So our first panelist, Dr. Suchi Jain, unfortunately because of an emergency, she's not been able to join us today. Next slide, please. Our next panelist is Dr. Nupur Nandi. Madam is additional professional. She is has teaching experience of more than 20 years. And she is currently working in the capacity of Professor, Department of Gynec and Obs at MGM Medical College and LSK Hospital, Kishanganj, Bihar. Welcome, Madam.
Thank you.
Our next panelist is Dr. Usha Sahadevan. Madam is DGO from Kasturba Medical College, Mangalore, consultant in Lotus Fetal Medicine Center, and senior consultant in Lotus Hospital, Erode since 2000. Past president of EOGS. Welcome, Madam.
Thank you.
Next is Dr. Manisha Jain. She is Treasurer, Bhopal OB-GYN Society, Executive Member of MPAGOI. She's faculty at many national and state conferences, consultant at Tiny Feet IVF Center, Professor OB-GYN at People's Medical College and Research Center, Bhopal. Welcome, Madam. Next is Dr. Ashish Varma. He's Assistant Professor at AMC Met Medical College and has Fellowship and Diploma in Minimal Access Surgery. Our next panelist is Dr. Jayesh Patel. Sir is Director and Consultant Arya Women's Hospital, Memnagar. He also has diploma in advanced gynecological laparoscopy and reproductive medicine. Welcome, sir.
Thank you.
Thank you so much, Pradnya. And I know because of the change of the schedule, we're going ahead with the panel. And we have the chairpersons also of the talk, Dr. Shweta Kumari, Dr.Yukti Wadhawan, and who have already joined. So if they can also be there and give inputs if they want to join the panel. And I'm really happy that Dr. Richa Sharma, I welcome you all. She's been the moderator today and she's the best person because she's doing so much in that subject of MTP. And we really want to make abortion safe because every woman needs access to safe abortion. And that is the motto behind this webinar. So welcome Dr. Manisha Jain, Dr. Jayesh Patel, Ashish Varma, Dr. Usha. A warm welcome to all of you and Dr. Nupur Nandi. So I hand over to Richa. She will go ahead with the panel. I'm there with you and I will be giving my comments as required. I know Richa and all the panelists are going to do a wonderful job. We are going to have a lovely discussion. Over to you, Dr. Richa Sharma.
Thank you, Dr. Komal Chavan. Thanks to you and the team A to Z task for organizing this webinar, and welcome all the panelists and the chairpersons. So I will just share the screen. Dr. Komal, you are really doing great and wish you all the best for the upcoming elections. We are with you. Dr. Komal, we all know she is contesting for the Vice President election.
Yes. Thank you so much.
Okay, so this is the okay, so now let us start the panel on safe abortion. So first of all, let us know what the safe abortion means. Now, after the recent MTP amendments also and already existent MTP Act, we all know it started in 1971, then undergone few amendments. Now we have the recent 2021 amendment. So what safe abortion means that if it is done by the person who is eligible to do the abortion and the place which is approved for the MTP, and then the indications are also there. So this means safe abortion. So now who can do the MTP? Now we are very clear after 2 years of amendments that if we are doing the MTP for less than 20 weeks, opinion of one registered medical practitioner opinion is needed. And if we are doing MTP between 20 to 24 weeks, then 2 RMP's opinion is needed. So now we are very clear about this. Now who can do the MTP and who can give the opinion? Now, in this forum, I think we are the gynecologists, so we all are eligible to do MTP up to and beyond 24 weeks. And then there are few categories in the MBBS registered medical practitioner. I'm not going into that detail. So we can do the MTP up to 24 weeks. And then after 24 weeks, medical board approval is required. So that is about who can give the opinion and who can do the MTP. Now, after 24 weeks, if the approval is given by the medical board, then also the 2 registered medical practitioner name has to be written. That means the 2 RMPs have to do the MTP. Now, indications. Now, this slide is very important. We are clear with the indications now, different indications for different set of gestation. So up to 20 weeks, we have same old 5 indications which we had earlier before the amendments also. To save the life of mother, to prevent grave physical or a mental injury to the mother. Then if there's a risk of baby having congenital anomalies, humanitarian ground rape and contraception failure. The only thing which has been changed is now it will cover the unmarried woman also. Then upper limit is increased to 24 weeks. We all can see now only 7 category of women, they are entitled for MTP till 24 weeks. So they are the survivors of the sexual assault, rape, incest or minors. Or if the woman has become divorced or widow, women having physical disability or mental illness, including mental retardation, and then fetal malformations. Now, those malformations only which are incompatible with life, or if there is a risk that the baby can have serious physical and a mental handicap after birth. So only those anomalies. And then women with pregnancy in humanitarian setting. Now, unmarried women also are included now in this category up to 24 weeks after the Supreme Court order. After 24 weeks, now the indication is only and only for the fetal congenital anomalies. After 24 weeks, if the unmarried woman comes for MTP or there is a sexual assault of a minor or any other indication, in that case, the board does not have any discretion. Board has a discretion only for the congenital anomalies. So in that cases, the patient again has to file the writ petition. If she is an unmarried or a sexual assault victim or any other indication coming after 24 weeks. So in that case, board will not take the decision. It is the purview of the court. So we have to file the writ petition. Now, where MTP can be done? Now, in any government hospitals, they don't have to take any separate approval, but the private hospitals or the private setup has to take the approval for the MTP. Then now complications. Now there are 2 types of complications. One is the medico-legal complications with which we are worried about, and other is the physical and the mental complication for the patients. Now the rate of the complication is very less if we are doing the MTP in early gestation as compared to late gestation. Now with this background, now I ask the question from any of the panelists. Now a patient who is Gravida 2, Para 1, Living 1, she has come for MTP at 9 weeks and she wants MTP by tablets. And her indication is the failure of contraception. Now you want to prescribe the medical method of abortion. So what do you mean by medical method of abortion and what are your specific instructions to this patient? Anyone can answer one at a time and others can contribute.
This is Dr. Usha. So MMA is medical method of abortion. And normally we give mifepristone followed by misoprostol. So the mifepristone is given on day 1 and the patient takes it in front of the doctor. And she's asked to come back after 2 days to take the misoprostol, 2 tablets of 200 microgram each. And then we teach her about what are all the expected symptoms, like that she will have pain, she'll have bleeding, and some amount of cramps are also expected. And then we have to give her the warning symptoms also, like if she's bleeding excessively, that is more than 2 pads in for every hour for 2 hours, or if she has fever, chills, or rigors, or vomiting. So all this, she has to be educated and she has to be called on after 2 weeks to make sure that the abortion is complete. And I have a small doubt here. Is it up to 7 weeks we are allowed to do, or up to 9 weeks?
I will come to that. Okay, so these instructions include what all Dr. Usha has said. In addition, I just want to highlight this MMA card. This is from the government. You can devise your own card, but should cover all the points. What is more important, that the hospital name has to be clearly written, then the contact number also, has to be written clearly so that the patient can approach at the time of complications. And complications or the danger signs we have to explain to her. And now the medical method. Now, when we say medical method, it means MMA up to 9 weeks. Okay, so medical method using mifepristone and misoprostol, it is approved till 9 weeks in India by the government of India. And then after 9 weeks, now there is again a gray area. Now in 9 to 12 weeks, they have not mentioned anything. So you can go for the surgical termination of pregnancy. But if you read the document of Government of India Comprehensive Abortion Care Guidelines clearly, they clearly mention that MMA is up to 9 weeks. But then again, they give the reference of WHO over there only, saying that the mifi and misoprostol drugs, they are very much effective and the very low complication rates after that also, in the second trimester also, and beyond 9 weeks also. So indirectly, they are giving us the hint, but as of now, it is not approved in India. So the WHO regime, WHO has given a very good regime. I think all of us are using all these regimes and they are very good also. So less than 12 weeks, as you have said, we use a mifepristone 200. So mifepristone dose remains the same throughout the gestation. It is only the misoprost dose which keeps on changing. So less than 12 weeks, we use 200 of mifepristone, and then on day 3, you use the 800 micrograms of misoprost. That can be buccal, pervaginal, or sublingual. So, but now you can give on day 2 also, but the minimum interval between the mifepristone and misoprostol has to be 24 hours. Okay, and after 12 weeks, we give misoprost 400 micrograms every 3 hours. So now the maximum dose has been removed. Earlier, there was like you use the 5 doses and then you stop, but now there is no maximum limit. You use according to the findings. So this is a change in the WHO. Now, MMA regime, they are very much effective, but you just have to ensure the contraindications are not there, like the anemia should not be there, HP should be at least 8 grams, and then uncontrolled hypertension, diabetes, or convulsions, all these things are not there. And the results are very good. It is 95 to 99% effective. But one thing is important, whenever you are giving a mifi and misoprost regime, you have to counsel a patient properly that there is a chance that 1 to 3% of the women, they may have the congenital anomalies also. Like it is a teratogenic drug. There are few case reports wherein the Mobius syndrome has been documented if the failure of mifi and miso was there and the pregnancy was carried out. So Mobius syndrome, it is the 6th cranial nerve palsy along with few associated syndromes. So we have to counsel that for also. And if the patient has a failure of the medical method, we have to tell her she may land up in the vacuum aspiration also. So these are the 2 specific other things we should tell them. And coming to the drug protocols, I have told you. So now apart from the mifi and miso, now the WHO now recent guidelines, they have added the letrozole also, and they say that it gives a very good result. So up to 14 weeks, the combination of letrozole on day 1 and then day 4, you give misoprost. It is quite effective, 800 micrograms sublingual. And then after that, the regimes is according to the FIGO and the RCOG and WHO. Now I have summed up the entire this regime. So 12 to 24 weeks, the mifepristone dose remains the same throughout the gestation. Only the miso change. So 12 to 24 weeks, the miso you should use is 400 micrograms. Then 25 to 28 weeks, you decrease it to 200. And then if you are going beyond 28 weeks MTP, then even decrease to 200 milligrams, 100 micrograms of miso. Yeah. So, but what about the scarred uterus? There is no clear-cut guidelines regarding that. Risk of uterine rupture, certainly it is there, although it is very less, 0.3%. So in that case, in second trimester, there's no clear-cut guideline. First trimester, lot of studies has been done, lot of papers are there, but there is no difference in the complication rate. It is only the second trimester and beyond. So now, what you can do is either you reduce the dose to half or you prolong the interval. Instead of 3 hours repeating, you go for 6 hours. That is one option. Or decrease the dose. Instead of 400, you come to 200. Just decrease the dose. And third option is that the IUD, whatever the regimes we are using, that is a mifepristone, 200 milligrams 3 times a day for 48 hours. So this regime, which has been given by several papers, and it is very effective for the IUD, intrauterine deaths. So in MTPs also, the baby is disregarded. Okay, so that regime also is quite effective. So we have done the FOXY GCPR on MTP up to and beyond 24 weeks, and we have documented all these points in that. So we will be circulating the GCPR very soon to everyone. So this is about this. Now, rapid fire question is, what are the minimum investigations you should do before any MTP in a low risk woman?
One is, hello, am I audible?
No, I can't hear.
Hello.
Recommended investigation as such. We need not do an investigation.
Blood grouping.
Except for blood grouping, maybe.
Blood grouping has to be done, and Rh negative women should receive anti-D.
Yes, blood grouping is there. Yes, one is blood group. What are the minimum investigations? Okay, not the treatment. Blood group, yes, certainly.
Well, gestation has to be certain. So if the periods are regular, then it's okay. Or doing a examination of the patient, or else it is better USG if patient could afford. Then an USG to be sure about the gestational age and location of the pregnancy. And at the same time, while doing blood grouping, a hemoglobin estimation, clinical estimation, if it looks like patient is anemic, then also we should be a little bit aware about the hemoglobin level, because the medications sometimes causes significant bleeding. So
yeah, so minimum investigation for a low risk patient. These are 3 investigations, as you all said. Hemoglobin, yes. Blood group and RH typing, that is one, and then urine routine and microscopy is required. Now ultrasound, it is not at all mandatory, but then you do your clinical examination. If you have slightest doubt, you go ahead with the ultrasound. So ultrasound, basically in the early trimester, we want to rule out the ectopic gestation, because we are not really able to do so. And also if the patient is having the previous scarred uterus, we want to rule out the scar ectopic pregnancy also. So these are the few things. And then can you prescribe medical method on a phone or a telemedicine without any visits?
No, we can't.
No. Why?
Form C has to be signed by the patient, and Form I has to be
yeah, basically the consent form has to be signed. That is very important. And then if you want to do any other clinical examination or anything, so one visit is mandatory.
Detailed counseling is also required to ensure compliance of the patient.
Manisha, your voice is not audible. Yeah.
Detailed counseling is also required to ensure compliance of the patient.
Yeah, see, counseling and everything you can do on phone, telemedicine, everything. And you can advise the investigations also on the phone. Okay, so everything. But yes, one visit has to be there for the consent form. That is mandatory. So we cannot really go with that. Now, why it is mandatory? Why we are saying so? Because see, MTP, it is governed by the law. It is an act. So whenever we deviate from the person who is not eligible to do, or the place which is not eligible where the MTP should be done, there's no indication. So these are considered as a serious offenses, and punishments are also there. Okay, between 2 to 7 years, the rigorous imprisonment is there if the person who is not authorized or the place not authorized. And then documentation also is important, because now the 1 year of imprisonment is added to 1,000 rupees, which was already existing. And then if you are doing the MTP without any indication, I've already shown you the indications. So if the indications are not there, and if the MTP is done, then the imprisonments are there between 3 years to 7 years, or up to 10 years also, depending upon what period of gestation you are doing. And the person who is doing the MTP and the woman are also liable. The patient, she is also liable for the punishment. If without indication, she is undergoing the MTP. So these are the various sections which are applicable in Indian Penal Code 312 to 16. And then consent is very, very important. You cannot do MTP without consent, or else there's a life imprisonment or up to 10 years with a fine. So these are the very serious offenses. So that's why we have to take the MTP with a pinch of salt. And then especially if there's a death because of MTP, without any consent was not taken for MTP, or even consent was taken for MTP, but however there's a death while you are doing the MTP or after that, then also there are punishments. So what I just want to highlight from this is that you don't stop doing MTP, but you do MTP as per the law and as per the protocols. As far as your paperwork, your drug protocols and everything is intact in the place, so you won't be liable for any kind of offenses or the punishments. Now, do you want to give the antibiotic? Now, this same patient, you had given the medical method of abortion, and after a few days, she came back with fever, breathlessness, and pain. Okay, and then now I just want to ask, do you want to give antibiotics for medical method of abortion?
If
No.
urine report or any other report suggest increased TLC, but rather than it is not important to give
At the time, this is, I am asking, do you want to give antibiotics along
No.
with medical method of abortion?
No.
Yes.
Not as a
So
routine.
it is not to be given only if you are suspecting any infection is there, already existing
Yeah.
infection was there, and also the patient who are nulliparous actually. So in those cases, we should consider the antibiotics with the medical method, because we want to avoid the intrauterine adhesions. We want to, don't want her to get the infections. And the regime is doxycycline with metronidazole, or you can give azithromycin with metronidazole. So that is one thing. But surgical abortion, yes, you have to consider the antibiotics. Okay. So now, which place do you think MTP should be done after 24 weeks?
Medical college, any tertiary care center. Yeah.
Yes. So it should be done in the tertiary care center, preferably medical college. Now, how do you want to dispose the product of conception in first trimester and then second trimester, and then now upper limit is increased also third trimester if you have done MTP for GCA? So how will you dispose the POCs? Anybody?
Generally, madam, it is after at 24 weeks, it is fully aborted. Then we sign the tender, or if they want to take, we can sign it from them. And with consent, and we can sign it and from return it by return the information that can be given to them near 20 to 24.
Yeah, second trimester. Yes.
Yeah. Yes,
so
but
second trimester, the fetus is formed. And Dr.
Yeah.
Ashish, this is what you want to say. So well-formed fetus, second trimester, you hand over to the attendants.
We can hand over.
And take the signature that they have received the fetus.
Yeah.
Okay.
Yes.
Now for the product of conception, first trimester, how do you want to dispose it? You must have done the suction evacuation. So again, it goes into the yellow color
biomedical waste. Yeah,
biomedical waste.
Just dispose like that. So that is one thing. And but if you are, but still birth form has to be filled. If you are doing the MTP and you are handing over to the relatives after 20 weeks, so still birth form has to be filled. So that you have to keep in mind. Now documentation is very important aspect of MTP Act. So either you are giving medical method of abortion, mifepristone, miso in first trimester or second trimester or after that, or either you are doing vacuum aspiration. Okay, so in any case of MTP, you have to fill these 4 types of forms. That is consent form, registered medical practitioner opinion form, monthly reporting form, and then the admission register. So this is the consent form. Now consent, we all know whose consent is needed is just the patient's consent who is more than 18 years. Okay, but if less than 18 years, then the guardian will sign, and guardian need not be the blood relative. Now this is the form 1. Now form 1 we have to fill if we are doing MTP till 20 weeks, because we all know now till 20 weeks only 1 RMP opinion is needed. So we will fill this form. Now this is the first half of the form, and this is the second half of the form. So all the 5 indications are written. 5th one, it is already amended. I have told you it will cover the unmarried women also. Then the RMP has to sign. Now this is form E, which has been introduced. So it is MTP between 20 to 24 weeks. So this is a form E we have to fill. Details of 2 RMP has to be written. Then the details of the patient. And then 7 categories are written. You have to choose whichever is appropriate. And then the signature of the 2 RMPs has to be there. Now, this is the format of the form D, that is a medical board approval or denial form, that is for after 24 weeks. Now, this is the format of the form 2. Now, each month you have to send the your entries, whatever MTPs you have done in the previous month, you have to send the data to the district authorities of your area. So, this is the format. You have to write the total number of MTPs at different period of gestation which you have done. And then total number of women who are in the different religion, you have to write it. Then the indications, total number of the indications, different indications you have to write. And then here the family planning head or the head of the hospital has to sign and send it to the district authorities every month within the first week, preferably first week of each month. Now this is the form 3, which is very important. Now here it has the 16 columns. Okay, and each year you have to start the new register. It should have 16 columns. All these columns are fixed. You have to make your register this way. Write the serial number, date of admission, and details of the patients. 2 new columns, 15 and 16 has been added after the amendment. That is the procedure by which you are doing the MTP and the contraception part. Now, all these documents are very confidential. You have to keep them under the custody, at least preserve for 5 years. That is very important. So now to again summarize is RMP opinion form, that is 1 or E or D, and consent form, you have to keep it very safely, and then form 2, monthly reporting form, and form 3. So you have to seal it properly, keep under lock and key, because these are supposed to be the secret documents. Now, will you fill, now the rapid fire question is, will you fill these forms if there is a ectopic pregnancy or a missed abortion?
Not needed.
Do you want to fill?
Not
No, yeah.
required.
So it is not to be filled, because either patient comes with incomplete abortion, missed or ectopic or any other, you don't have to fill. Why? Because MTP means we are terminating the live pregnancy. Okay, and live and normally localized one.
We don't have to fill the form. Yeah.
Yes.
While setting the monthly report, we have to report the number of abortions, but we don't fill the form.
Yeah, so that data you can maintain, but so MTP forms you don't have to fill, so that you have to keep in mind. Then okay, now this patient who has come, you have given the medical method of abortion, okay, and then she has come with fever, pain, abdominal pain, and now you have given the antibiotics, you have done the ultrasound, and you have seen there is a highly vascularized mass inside the uterine cavity. Now, what will you do for her now? How do you want to proceed?
It is highly vascularized, then madam, we have to actually rule out the aortic, that it is what we can say.
GTN? You want to say GTN or AV
thinking of
malformation?
AV malformation usually, actually, if it is so much vascular, because V-mole generally doesn't look like this picture actually.
Fever and abdominal
No, I
pain.
think here the vascularity is only in
Sepsis
the
also.
endometrium. So if it is AV malformation, you will have vascularity in the myometrium also. So this
Yeah.
I feel it is only a retained products of conception.
Yeah. See, product of conception need not be avascular one only. Okay, if you see the radiological classification, there are 4 types of POCs are there. It can be avascular, which is type 1. Okay, minimum vascularity can be there, then moderate vascularity, and they can be even highly vascularized mass. So what is more important for you to see, if it is a mass which is contained inside the uterine cavity. Okay, so it is probably a retained product of conception. So how you differentiate this from AV malformation, as Dr. Usha has already said, that you will see the vascularity in the myometrium also. Okay. And then GTN also the same picture, you will see there will be the interface will not be maintained. Okay, here you can see the picture, the mass is well contained inside the uterus only. But still, if you have a doubt or anything, you can again do the beta SCG and then can rule out the GTN if at all. Okay, so now how you want to proceed now? Now RPOC is there inside the uterine cavity and she's having fever, pain. How do you want to manage this case?
Septicemia is to be ruled out, and the TLC count we have to see, we have to give higher antibiotics, and we have to rule out the other causes for fever and
Yes.
other causes for abdominal pain also.
Yeah.
So we have to see the upper abdomen USG also, if there is a free fluid or there is like this something, or if she might get gone for some septic abortion or like that, we history, and that we have to see. We have to take a vaginal swab culture if we can wait for 1 or 2 days also. We have to rule out all the other causes for that septicemia.
Yeah. So very rightly said, Dr. Ashish. Any patient who comes with all these symptoms, even if she has undergone a medical method of abortion and you have the scan before that, still it is always better to do the ultrasound again. Why? Because certain conditions, appendicitis, pyelonephritis, all these things can also mimic the picture of post-abortal sepsis. So if ultrasound says there is a mass inside the cavity, so you have to evacuate the uterus. Now, in this case, the patient is having a fever. The signs of sepsis are there. Okay, so you can do the bedside quickly. You can assess the patient. That patient is having a sepsis. You can use any scoring. Now, this bedside scoring of modified Q SOFA is very simple. You can see. So if it is there, so in that case, you have to evacuate the uterus very fast. So you will have to resort to the surgical termination of pregnancy. So under the antibiotic coverage, you do the vacuum aspiration. That is the best choice. And send the POCs for the cultures. And don't do the sharp curate at all. Okay, it is not required. And yeah. So, but if the patient is not having any kind of these sepsis features are not there, and you have just patient has come with some amount of discharge or some amount of pain, and she is not really in sepsis, and you find the POCs inside the uterine cavity, so you can consider giving her the mifepristone also. So yeah, sorry, misoprostol tablet. So misoprostol tablet, again, the dose you have to remember, if it is less than 13 weeks, you can give 600 oral or 400 sublingual. And if it is more than 13 weeks, then you can consider giving 400 micrograms every 3 hours. Now, what is more important is you have to give the doses according to the uterine height, not the period of gestation. And once you give these tablet, misoprostol tablet, you wait for at least 1 week. Okay, it is not you give the tablet today and start doing the ultrasound next day, and why the POCs are not out. Okay, and that is one thing. At least 1 week you have to wait, but you have to intervene if she is having bleeding or if she is having infection. Certainly you have to intervene. And then antibiotic, of course, you have to give the good coverage of gram-positive, negative, and anaerobes also. And once the patient, suppose the patient who has come in a frank, yes.
I'm Dr. Shweta from Jamshedpur. I would like to add one thing.
Yes.
That product of conception can be sent for histopathological examination if we have doubts for molar or something.
Yeah, sure. So
Not in all
culture
cases,
you have to, yeah.
And it should be sent.
Yes. And once you have done the evacuation, especially the patient who has come with sepsis, okay, you do the evacuation, then don't leave the patient then and there, because there are some patients who don't improve. So at least 48 hours you monitor them and give a good IV antibiotics. And if they improve, well and good, switch over to oral. And if suppose they don't improve, then you again do the imaging and rule out the pyoperitoneum or any foci of pus elsewhere. So that is very important.
And the evacuation should be done with Carmen's cannula, plastic Carmen. That is
preferred. Yeah. So vacuum aspiration we have done. Yeah, either you can use whatever either Carmen's or Easy Grip, whatever is available. Okay, both are silicone made. Now, this case, suppose you have decided to do the another patient whom you want to do the MTP. Okay, and you have decided for surgical termination of pregnancy. Okay, so do you want to give the anesthesia? Which type of anesthesia or analgesia do you want to consider?
I would prefer TIVA, yeah.
Yeah, madam.
Short J I would prefer, so that complete evacuation is there.
Yes, short GA, propofol.
Yeah, conscious sedation. Okay, so that is a conscious sedation or a paracervical block. Okay, so GA actually should not be given. We call it a short GA. So actually it is a conscious sedation. Yeah. So now quickly. So now if suppose Dr. Manisha wants to use MBA and Dr. Shweta wants to use EBA, is there any difference in these two modalities? For surgical termination of pregnancy?
Except for the equipments, I don't think there is any difference in the results.
Now the person is comfortable with whichever equipment.
Yeah, so that is the one thing, because the pressure generation, everything is same. So it depends upon your availability and your choice. Okay, so the efficacy is same in both the things. Now there are the WHO. Now, if you are attempting the surgical termination of pregnancy, vacuum aspiration, so cervical preparation plays a very important role. So these are the regime and the duration which has been given by the new WHO guidelines. You all can refer. So now suppose you have given her a medical method, the same patient, and it has failed. Failed means there is no bleeding for 24 hours after the misoprostol tablet. So how will you proceed now?
Read the dose, yeah. And we can confirm first with the intrauterine or extrauterine pregnancy.
Yes. Oh, again, you do the clinical assessment. That is fine. Yeah.
And we can repeat the dose if it's intrauterine. Again, we can repeat misoprostol.
Yeah. So it is your choice. You can repeat the dose or you can do the vacuum aspiration. So this is why I wanted to highlight this, is that whenever we are giving MMA, we have to tell the patient the possibility of this, and she can be taken up for vacuum aspiration. So she has to be counseled beforehand.
Madam, just I want to add that certainly I just counsel the patient. Some patients they say that after taking mifepristone they have they have the feeling of nauseating, or certain patient vomit also. That's why if they vomit that tablet, then they should inform us that thing. That's why.
Yeah. So yeah, so that is very important. Very good point you have highlighted, Dr. Ashish. So that is one of the thing. Whenever we are giving MMA, we have to give one extra tablet of misoprostol to the patient, and we have to tell her that if she vomits within half an hour of that tablet, then again she can take. Okay. So that is so that's why we always give one extra tablet.
Even I add ondansetron also with that.
Yeah, if she's having nausea and vomiting, you can give antiemetic tablet, whatever is your choice. Now, this is another case. Now, you have done a surgical MTP. You have done the vacuum aspiration for this patient at 7 weeks. According to you, everything went well. And then you shifted her to post-op room. And then in post-op, the people who were monitoring, suddenly they came and said that patient is having tachycardia, hypotension, and she is looking pale. And there's bleeding also from the vagina. And she is a primey. She was a primey, and she has undergone MTP because of contraception failure. So what do you think could be the cause, and how would you manage her?
I would suspect first as a maybe perforation. I like to rule out because she has undergone surgical termination.
Yes, one possibility is perforation.
Cervical lacerations.
Retained,
yes,
possible.
cervical
Or
laceration.
Or it could be an incomplete abortion also.
Yes.
Yeah,
So that is more, yeah. So that's why I wanted to tell, see, cervical laceration and incomplete is the first thing which we will think of. Uterine perforation actually should be ideally picked up intraoperatively.
Yeah, that should
so we should not miss. Yeah. So if there's a cervical laceration, so wherever the cervix is lacerated, either you can give a compression, you just press that area, it goes off, but the bleeding who has got so much of hypotension and tachycardia obviously will require the suturing. So you can take the stitch wherever the laceration is there. And if it does not get controlled, then other procedures are there, which we all know. And if it is an incomplete evacuation, then you can do the complete evacuation. So that is the thing. So in this point, I want to ask, what are the signs of complete evacuation? If you are doing the vacuum aspiration, so what are the signs?
The gripping and the gritting sign. We generally
gripping
and the gritting.
Okay, so gripping and the gritting, and then the bubbles also you will find.
Yes.
The bleeding stops. We get a gripping sensation. Yeah.
Yes. So these are the all signs so that we can stop and we don't have the incomplete abortion. Okay.
Actually, madam, again, I want to highlight that I have seen some patient where they have tendency of bleeding. Actually, so we have to actually ask certain time before going for a surgical procedure that if you have a certain history of bleeding or that, then certainly some patient.
So, patient evaluation and patient selection, it goes without saying. We have to take a very good history, clinical, physical examination and everything. And if anything is required, you do the investigation. See, minimum 3 investigation I have told, it doesn't mean you have to stick to that only. That is for the low risk patient. But any patient which require any kind of investigation, you have to individualize. Okay, another patient.
So any patient undergoing surgical evacuation, I will prefer always a complete hemogram to rule out any
surgical.
Complete evaluation, and also the ultrasound is important.
Some sort of sedation. Yes, ultrasound also, because they are undergoing sedation and then surgical termination. So it is better to do investigations.
So one difference between medical method and surgical, and why you are doing ultrasound, is to rule out the uterine anomalies also. Okay, at times you may have uterine anomalies and you are trying to evacuate the one side. So that is another one for the vacuum aspiration or the surgical termination if you are taking.
Nowadays with the rising cesarean section, we have to rule out scar ectopics also, because
scar ectopics, ectopic pregnancies, those we have to rule out. And surgical per se, you rule out the uterine anomalies also, so that you are not misled. Okay, so now another patient, previous 3 cesarean. Now she has come at 22 weeks with multiple congenital anomalies around. And you have decided for MTP because she is having anomalies. So how will you proceed now with this patient?
This patient would require a thorough counseling, that she is a high-risk woman. In view of previous 3 LSCs, there are more chances of scar rupture and lesions. And after all those legal formalities are done for termination, then she prefer her to admit the patient and evaluate her in view of hysterectomy rather than trying for medical abortion.
Okay. So hysterectomy and ligation, this is your choice. What about using Miffy and Meso tablet?
We prefer generally catheter, cervical catheter, madam. We are doing
Police catheter. Okay.
yes, cervical police catheter intracervical. Then we are with mifepristone. Then or after 24 hours we add misoprostol, and we actually counsel the patient about the consequences of previous 3 cesarean. So if she is willing to take, we counsel that we have this much patient we have and this much are the chances, but some patient have this much chances. So
what is the dose you are using for misoprost? So you are putting police catheter on day 1 and Miffy tablet also you are giving orally.
Mifepristone, yes.
Mifepristone.
After 24 hours, or if patient, if we can add even with mifepristone also 200 tablets 6 hourly misoprostol.
So Miffy and Meso together you want to give?
Yeah, Miffy on same day. Same day we can start with misoprostol also. Miffy cervical catheter, mifepristone, then 6 hourly misoprostol we can start with.
So at least an interval of 40 and 24 hours you are maintaining, right?
After mifepristone we can wait, or if we can even add misoprostol also. Sometimes I've seen that catheter is out by 6 hours after the misoprostol.
Yeah, that is fine. So Foley's catheter when we put, so usually 12 hours we give, okay, 12 hours and with mechanical dilatation we put a nice traction and everything.
Yes.
Okay, Miffy also you can give, but Meso I doubt because at least Miffy and Meso 24 hours.
We are not confident.
Yes. So yeah, so Meso, that's why I'm asking Dr. Ashish, are you reducing the dose or you're giving the same dose? What is your experience, sir?
200 we can give, madam, 6 hourly. I have not seen any rupture for previous 3 CS also at 22 weeks. This is just the baby weight will be near about 400 or 350 to 400 grams. So generally with catheter and mifepristone we can start misoprostol with 200, or we can wait for 24 hours. There is a smooth that will also go smoothly.
So according to all the guidelines and all the papers, I think the minimum interval we have to see between Miffy and Meso 24 hours. It should not be given simultaneously. That is one thing. And there is no clear-cut guidelines for cesareans. So Foley's catheter you can give, and then Miffy you can try. And Meso, like in our center also, we are not using misoprost tablet for previous 2 cesarean or previous 3 cesareans. But yes, mifepristone, as I already told, 200 milligrams 3 times a day for 48 hours. So it also works very nicely.
Yes.
So that is the one thing. And another best option, as Dr. Nupur has said, is hysterectomy, and if she is willing for ligation also. That is another option. But we have to have the ultrasound first. We have to rule out the placenta previa accreta.
Placenta accreta also we have.
So that is very important. We have to rule out with blood and availability of anesthetist and proper counseling and everything. Dr. Nupur, you wanted to add something?
Consent for hysterectomy should be there, even if we are trying for them.
Yeah, hysterectomy consent has to be there. Now, what is the diagnosis now? This should not happen, but if it has happened or patient has been referred to you, 29 years old, multi, referred from a nearby hospital with severe anemia and yellow mass coming out from the os. She had undergone surgical abortion.
Already uterus is perforated and momentum or gut
perforation and momentum has come out. This should not happen. So this is unsafe abortion. Now, how do we diagnose uterine perforation? We have already discussed. Now, how will you manage this patient now?
Admission.
Yes.
After admitting the patient, all the investigations are to be done, and then definitely patient has to be resuscitated at the same time with fluids, plenty of fluids, and according to the
blood, antibiotics, IV fluids, everything. And then specifically what we want to do now.
And what amount of perforation we are anticipating, with a small perforation or is a multiple perforation or associated blood bowel injuries that also have to be taken care of.
Peritonitis.
Okay, so you want to do everything on your own, or you want to call surgeons also?
Surgeon. We should always
so that is a very good idea to call the surgeons. Okay.
Bowel
And
has
then
to
how we will proceed now?
A patient should be always, madam, stabilized. The blood products and products should
Yeah,
be
that is everything is
cross-matched.
done. Now the whatever the momentum is coming out, do you want to excise it or you want to send it back to the abdominal cavity?
It is in septicemia. If we see a foul smelling or something like that, that momentum is infected, we should remove that thing, madam.
And whatever the perforation is there, you suture it. Okay, and bowel exploration is very important.
Yeah,
thorough systematic bowel exploration has to.
Bowel exploration has to be very important.
Always.
You have to take the help of surgeon, let them explore it. If everything is fine, okay, then you close the uterus, and if it is
Injury might be in other
evacuation,
sites also.
you complete the evacuation. Dr. Nupur?
Yes. Yes. Injury might be in other sites
Yeah.
also. Besides
And
guts and
better
all,
leave a
so we
drain
have to
also.
check
Yeah,
thoroughly.
always.
And
If any doubtful, then
after
we leave
completing the procedure,
Yes.
good peritoneal wash, and then keeping a drain definitely is a must.
Yes.
For this.
Generally, we are doing metronidazole wash in such cases. We have with some septicemia.
Okay. Now
Normal
suppose
saline wash
yeah.
is okay. So metronidazole locally does not work that much, and
good saline wash, I think, is all that is.
Yes.
Enough. Now suppose this patient, you were doing the MTP or your junior was doing, okay, and suddenly they felt that there's a loss of resistance, okay, so that the uterus has perforated. Now how will you manage that case now?
Immediately.
Type of instrument has to be assured first.
Yeah.
If the instrument is very small, then only conservative management.
Small means what, Dr. Nupur? Can it be small?
Small means lesser diameter dilators.
Blunt.
Then patient may not require anything, and if there is no bleeding at all, so we can we'll keep the patient admitted.
Yes.
And monitored.
Observe the patient for 1 hour.
We have to explain the procedure. Procedure can be done later on. Evacuation process should not be done at the same time. Or if it is with a big instrument, then we can proceed for just seeing under lab coverage. We will proceed for the evacuation process also at the same sitting. And whether the perforated site has to be repaired or not, that is a decision has to be taken. But at the very beginning, without proceeding for further, if it is with a small instrument, we can conservatively follow the patient for few hours.
Better to do diagnostic laparoscopy. Put in a laparoscopy.
Yeah. So the take-home message is that whenever we have an intraoperative perforation, we have diagnosed. If it is from the dilators, we just monitor the patient. Okay. But if it is from the cannula, okay, with the suction machine on and the Carmen's cannula or anything, then it is always better to do the laparoscopy or laparotomy according to the facility, whatever you have. Okay, so why we want to stress this point is that there can be a bowel perforation can be there, bowel injuries can be there. Okay, yes. But in such cases, suppose
one more advantage is you can
with the Carmen's cannula and the perforation is there and the bowel injury is there, and you have left the patient for just to monitor it. Okay, that is not to be done, because if you are monitoring the patient, day 3 patient will have the peritonitis. Okay. If she is having a bowel injury, the patient will not bleed or anything. Usually they remain silent till you start the orals or something, and then they land up with peritonitis. Now, once they land up with peritonitis, then you don't have any other choice but to do the bowel resection, and anastomosis cannot be done. Okay, that time. Then you have to land up with the colostomies. So that is very, that increases a lot of morbidity for the patient. So let it be a negative laparoscopy or laparotomy. But whenever you are having the perforation with Carmen's cannula and the machine, suction machine on, it is always better to have a look about the bowel with laparoscopy or laparotomy. Rapid fire question now again. What should be the direction of dilator while dilating the cervix? Anterior, posterior, or in the direction of uterine cavity? Very basic question.
Actually, if we the direction of the uterus, but if we pull the cervix towards us, then most of the uterus has become straightened. That has to be followed. So acutely anteverted uterus, unless it is acutely anteverted or retroverted fixed, all uterus will be straightened if we pull the cervix towards us a little bit. That has to be followed for termination of pregnancy or whatever the procedure, blind procedure done with the uterus.
Yeah. Okay. So this is now last case, one very important message we want to highlight. So this is a 23-year-old patient, 6 weeks of pregnancy. She came with excessive bleeding and she had a urine pregnancy done, but ultrasound was not done. And at that time, she has taken a MTP pill from the chemist shop. And she has one cesarean also 2 years back. So now she has come to you and she is bleeding excessively. And you have done the ultrasound and now you find the heterogeneous lesion in the lower part of the uterus and the impression is incomplete abortion. So now you plan to take her up for DNC or vacuum aspiration. Okay, so what are the precautions you should take? Or suppose you have done the DNC and there's a gush of blood and she becomes vitally unstable. So what is your diagnosis in that case?
Cesarean scar pregnancy.
Yes.
Most likely.
During ultrasound, we can do the sliding test.
Ultrasound is not done, then we can assume for VMOL also. That can be, we can see, we have to see the size of the uterus also. That is, you have taken MTP pill, can be VMOL also sometimes.
Okay, so the two important message I want to highlight is that MTP pill, it is a Schedule H drug. It should not be taken from the chemist. It should be given only under the prescription. That is one thing. Okay,
But
and secondly is that
the
previous cesarean section patient, it is always better to have the ultrasound. And after ultrasound, suppose if you find a gestation sac which is a low down, close to the sac, close to the scar, or think it is a scar pregnancy, and you deal that way. So that is very important. Any previous cesarean coming with excessive bleeding after MTP pill, think it is a scar pregnancy and take all the precautions.
So that is differentiate from
okay, so should we take the consent for hysterectomy also whenever you are taking the patient of cervical pregnancy or scar pregnancy for MTP?
Yes, of course.
So it has to be taken. Yes. Any role of interventional radiologist in such cases?
Yes.
Yes, uterine artery embolization can be done before the procedure.
Yes, if the facilities are there, it works the best. Now, do you recommend pre and post MTP ultrasound for patient safety? Not in this case, any other case also.
Yeah, it's better if the patient can afford and patient is willing, it's better to do ultrasound pre and post MTP.
Yeah, before MTP, yes, it is always wise to have the ultrasound. But after MTP,
yes.
After 2
I
weeks,
used to do for all my patients.
It should not be done routinely for all the patients until the patient is having any symptom. You do the clinical examination. If there's no infection, there's no discharge, and the uterine height also normal, everything, I think you can leave. You don't do the scan.
And if at all we are
Nowadays,
doing it
patients are more
routinely,
happy
do
if
it
you
later.
don't do
Don't do
examination.
it within 2-3 days. Do it at least after a week.
Dr. Shweta, you wanted to add something?
I asked the patient to wait for 2 weeks. Actually,
Yes.
I tell them that 7 to 10 days bleeding will stop. If it doesn't stop after 2 weeks, then you get the ultrasound done and come back with the report.
Yes. So medical method, whenever we give, we tell that also that they can have some amount of spotting up to day 13.
Yeah, if the
Day
third
15,
visit is still bleeding, then we might advise her.
then we can advise a scan. Okay, so we have to correlate with clinical examination. So contraception is very important. And we all know in the first and second trimester, see all hormonal and non-hormonal contraceptives we can use after the first trimester and second trimester MTPs. And it is only the IUCDs which we have to restrict if we are giving the medical method of abortion, that we can put around day 15. But in second trimester, we can put simultaneously. And then sterilization also, we all know that first trimester we can do lap ligation or a mini lap, but second trimester we have to avoid lap ligation, and vasectomy at any time we can advise the patient. So one thing is important, we should not deny MTP if the patient has not chosen any kind of contraception. We should not force them to choose any kind of contraception. Okay, so we do the MTP. Next visit, when she comes, again you counsel for the contraception. If she takes, well and good. Otherwise, you keep on counseling it. But if we just cannot force them, and we cannot deny MTP because she has not opted for any contraceptive. So that is another thing. So with this, now we thank you. So it was a wonderful participation from all the panelists, and thank you so much from all of you.
Thank you so much, ma'am.
Thank you so much. ma'am.
Thank you. Thank you for this
Dr. Komal,
opportunity.
now we are waiting for your
Komal.
inputs.
Yes.
Excellent panel. Everybody did such fantastic answers, the rapid fires and the practical points which you brought forward. They were such good, because, the rules, regulation, changing trends, how to be safe, how to do when MTPs, you're doing it, if there is a perforation, I think all the points, failed MTPs, patient coming with drugs, everything was brought forward, and all the panelists, they have done such a lovely discussion. And Professor Nupur Nandi, Dr. Usha, Dr. Manisha Jain, Ashish Varma, Jayesh Patel, Shweta Kumari, I think they have done a fantastic job. Lovely panel, very practical, very, very practical. In fact, it was so simply, so simplified, that we can actually, when we know it, all the concepts become so clear because we know what are the guidelines, what we have to do, and how to go ahead. That all was simplified. Thank you so much, Dr. Richa.
Thank you, Dr. Komal,
Thank
Dr.
you,
Richa.
Dr.
Thank
so
you, Dr.
much.
Komal. And
All the
thank you all
best.
the panelists once
For the
again. And
election
once
also.
again,
All
Komal,
the
all the
to you,
best.
Dr. Komal.
Thank you so much, Dr. Manisha. Thank you.
Thank you, madam.
Yeah.
Good evening, Komal. Sorry, I was a little late.
Yes, welcome. Dr. Jeyarani has joined.
Yeah, sorry. I'm
Thank you all.
held up
all
in an
panelists.
emergency. I rushed
Yeah.
back.
Yes, now we have the talk which will be there. So Pradnya will take over. Over to you, Dr. Pradnya.
Thank you.
Welcome, ma'am. Now our chairpersons for this session are Dr.Nibha Mohan. Madam is consultant at Renu Maternity Center, Patna, treasurer, Patna OBGY Society. Welcome, madam. Dr.Yukti Wadhawan, she is director and consultant, Yukti IVF and Gynec Center, New Delhi, editorial board of Human Reproduction Journal, Ashray, Indian edition. Treasurer, Delhi Gynecologist Forum, West. Welcome, madam. Our next chairperson is Dr. Shweta Kumari. Madam is consultant obstetrician and gynecologist at Sri Satya Sai Sanjeevani Hospital, Jamshedpur, secretary Jamshedpur Obstetrics and Gynecological Society, and executive member of Medical Disorders in Pregnancy Committee. Welcome, madam. I now request our chairpersons to introduce our speaker, Dr. Jeyarani Kamaraj.
Yeah, before they go, I really must thank the chairpersons because the talk was delayed, but they are there. I'm so happy. Thank you, Dr. Yukti. Thank you, Dr. Shweta Kumari.
So much.
And I am really happy that you all are there. So over to you now to do the proceedings. Dr. Jeyarani is here.
So should I go through? Okay, so I'll introduce the speaker. Welcome, Dr. Jeyarani Kamaraj. Ma'am is a senior consultant of reproductive medicine at and director Akash Fertility Center and Hospital, Chennai. She's the president, OGSSI. She's the treasurer, Tapisar. And she has so many medals and awards to her name. It's a pleasure hearing from you, Dr. Jeyarani Kamaraj. Over to you, ma'am.
Thank you, chairperson. Thank you, Komal, for giving me this opportunity, and very special thanks to one and all for being patient to wait for me as I was held up in an emergency. And it is really a great pleasure to be here, to be with the Augustus audience and also the senior faculties here to speak on a very different topic, not from your routine obstetrics and gynec. It is something related to the sexual health, which we are all looking into a very great challenges which we see. Can you see my presentation?
Yes.
Yes, ma'am, we can see. Just make it full screen.
Well, yes.
The introductory slides.
Is it okay? Can you see that?
Yes, ma'am.
Yes.
So today we'll be talking on an interesting part of your fertility. I mean, rather we can say as a fertility as well as gynec, which is nowadays upcoming. We are looking into a very interesting part of a women's life, which is almost hidden, and which we never talk, which we never discuss, which we never open as a gynecologist. That is the female sexual functions, which cause a dysfunction in a woman. And that is a very, very important aspect in a woman's life, which every one of we gynecologists should ensure a proper care, because we are dealing with the organs of these sexual functions. And it is our responsibility as a gynecologist to look into the dysfunctions which is happening to a woman, which leads not only to an physical problem, it can lead to a lot of marital, psychological, as well as a lot of social problems because of this dysfunction. So it is a very important component in the women's life, which we have to look into her health. We all know the sexual health is a state of physical, emotional, mental, and social well-being related to the sexuality. And it's not merely the absence of a disease or dysfunction or infirmity. So it is a very important aspects of health disorder related to the sexuality. So we all know the sexual response cycle. When we look into the sexual response cycle, there have been a lot of different response cycles which has been formulated right from 1966 by the Master and Johnson, modified by Kaplan, modified by Whipple. They have given a lot of different sexual response cycle for a women, because for women, it is still the sexual response. It's little complex. Your sexual function is very complex. For a man, it looks little more easy to understand. But for a woman, the sexual response or the sexual response cycle is very complex. But the main components of the sexual response being the desire, which includes her thought, wishes, fancies, fantasies, everything comes into play. And the arousal, which is an excitement, which is a sexual sense, which causes a genital vasoconstriction, leading on to a lot of physical changes like the heart rate increasing, respiratory rate increasing, the blood pressure variations, which can all be aroused with the arousal. And orgasm, which is the peaking sexual pleasure, which is mainly leading on to the lower vaginal wall contractions, along with a lot of secretions from the genital organ, as well as leading to a resolution, which is a relaxation and sense of well-being. The phase may vary in sequence, which may overlap, or it may repeat, or may even absence, or it may present, or it may be partially present or a totally present. So many things can happen depending on very many factors. So the females are much motivated by the emotional and the psychological more than the organic problem. So that is why in a female, a sexual act may not even lead to an orgasm, because we always say the orgasm is something related to the lower vaginal muscle contractions. But for a woman, the orgasm lies in between her ears. That's what's in the brain. So the brain feels the orgasm, the pleasure, the happiness that she feels may be even similar to an orgasm, which is very much appreciated by a woman. That is why we may say that it's more an emotional and a psychological rather than an organic. So by definition, what is the female sexual dysfunction? The main issues of this being the absence of any of the conditions of the female sexual response. Either could be a decrease in the desire or arousal or orgasm, or it may cause some sexual pain. But very importantly, there should be a personal distress. Because if you look into the women's life, at some point of time, they may have a lot of dysfunctions. But to define as a dysfunction, it should be persistent for more than 6 months. But it should be associated along with the distress, causing the women to go through a distress. Because sometimes, even when you have a small episiotomy wound, you may have a sexual pain, you may have a discomfort, but that's not a dysfunction. It is due to some other reason. It can be corrected. But if that is persisting as a painful condition, lasting more than for 6 months, then we call it as a sexual dysfunction. That is a very important point that we should all note, because many times we have a lot of dysfunction. When you are mentally disabled by some disease, when you are low down with some psychological problem, you may go through some sort of a sexual dysfunction, but they are not distressing your personal life. If it is distressing and it is persisting for more than 6 months, then we call it as a sexual dysfunction, and we treat the women with the specific drugs or the therapy or any other process or any other medications depending on the conditions. So there are other things that we have to consider here, like which could be secondary to a medical or a psychiatric illness or due to a medication or a substance induced, but it should be a persistent, there should be an absence of this condition. So that is a very important point. So this FSD is associated with significant decrease in the health-related quality of life. That is why it's very important, because it has a large negative effects on the mental health, the vitality, and the social function of the women. And the affected women are more likely to be more psychologically depressed and dissatisfied, and they will have a lot of detachment in the home life, dissatisfied with the emotional and physical relationship with their partner, and thereby causing a lot of problem with their quality of life, which is the way it is very important. More than the physical ailment, they have a lot of psychological ailment. The overall effect of this sexual dysfunction on the quality of life is similar to the magnitude that it's related to the diabetes and the back pain. That's what is always there nagging, and thereby it has a lot of effects very similar to this condition. Let's look into the causes for the FSD. There are a lot of causes which may be overlapping. For example, it could be a hormonal, which may lead to a neurological, and because of the neurological, she may go in for some vascular. So everything comes to role, because the basic to proper sexual function depends upon the integrity of all these 4 factors, which could be the genital organs integrity, and that includes the vascular, neurological, and the hormonal, along with the psychosocial factors, play an important role in the pathophysiology of the sexual functions. So in addition, when there is a disruption of any of these factors, this may result in a sexual dysfunction. So this include not only the organic, like a hormonal, neurological, vascular, along with the relationship issues, social stress, mood, the sexual abuse, and the psychiatric, all those things play an important role. So we must encounter all this history when you are looking into a patient with this problem. So the neurotransmitters play a very important role in the female sexual function. And this requires a very delicate balance between the desire-producing neurocrine, that is the dopamine and the epinephrine, and the norepinephrine and the serotonin, which are almost needed for the orgasm and arousal. Disorders of the which could lead like a depressant, antidepressants, all this will disrupt these neurotransmitters, and thereby it may lead to an FSD. Many a times the hormonal deficits also play a very important role, as we all know. As we all know, the testosterone and the estrogens, they are the 2 main hormones for the sexual functions. We know pretty well in the menopause and in the perimenopause, or in any conditions where there is a hypoestrogenic conditions, this may lead to causing a lubrication disorders, causing a vulvovaginal lubrication problem, and leading on to decrease in the blood flow to the vulva, causing a decreased vasocongestion, which are very much needed for the sexual functions. So in cases of the vaginal atrophy, there is an effect of the sexual functions, causing either an FSD or as well as a sexual pain also. So whenever there is a decreased levels of estrogen, it is always associated with a decreased libido and a decreased sexual responsiveness, which may be interlinked. So androgens at the same time that plays a role in the women almost like a men, in maybe the difference in the concentration may be little variable, but definitely an androgens play a role in the female sexual functions. So when you come across any sexual problem, there is an overlap of one component with the other. For example, if there is a problem of atrophy, the vaginal or vulval atrophy, that may lead on to a lack of lubrication. This lack of lubrication may end in a pain, and this pain may end in a difficulty in the penetration, and that may end up in a sexual problem. So everything is interlinked. So one may overlap. You may think that she has a decreased lubrication, but they may ultimately end in a painful sex. So every part of this has an important role and play an important role in this. That is why many times when you look into a condition, we have to look into all the aspects of the sexual functions. Then we can put into a diagnosis of what is the problem, how it started, what should be the primary problem, how we can correct it. That will help us to differentiate as well as come to a diagnosis. So with this basis, we define or we classify the female sexual dysfunction into 4 important components. That is the female sexual desire or arousal disorder, And second is which includes the decreased desire disorders as well as sexual aversion disorders, a sexual pain disorder, which could be a vaginismus or it could be a painful conditions like vulvodynia, a female orgasmic disorders, and also there can be a persistent arousal disorder. So these are the 4 components as classified by the DSM-5 criteria. So when we look into the first, that is the sexual interest or the arousal disorder, what we call as SIAD. This is a DSM-5 classification which states that the hypoactive desire disorder is defined by a complete lack or significant reduction in the sexual interest and arousal, and it is diagnosed for 3 or more of the following symptoms should be there. Either one, the first one being so that this should include an absence of an interest in the sexual activity or a reduction of such. There may be a lack, total lack, or maybe a decrease, or in the absence of fantasizing or even thinking of erotic thoughts, which will be totally lagging in these women, as well as the female is disinclined to initiate sexual encounters with her partners or exhibit no sense of pleasure during the response or when they are expected to have a response in a sexual act. So these are the symptoms that can be presenting as a desire disorder or an arousal disorder. And these symptoms must have been persisted for a minimum of 6 months and results in distress on the part of the patient. And also there is no evidence of physical, biological or substance induced cause for this condition. That is a very important point, because there should not be any medical disorder, or it should not be a biological disorder, or there should not be any other disease which is contributing to this. With no reason, if she develops a problem, then we call that this could be a problem related to the sexual arousal disorder. The problem may be lifelong or it may be acquired. It could be there, mild, moderate and severe, depending on the condition and the patient's distress that she go through. So always there should not be any physical problem that she should have. It is more of a psychological problem. So there are the important things that we should rule out when women come with a desire disorder, mainly the medical disorders. Usually it could be any conditions like the diabetes or a coronary disease, or it could be due to hormonal deficiencies, or there can be due to any other drug intake, which could be usually an antidepressants. And also there are a lot of psychological issues as well as the stress issues, which could be the reason for the conditions. So there also we have to ask for the history of a depression, anxiety, and also partner related disorders, marital disharmony. All these things we should ask when a patient comes with, doctor, I have a low desire, I have a low arousal, I am feeling not happy about my sexual initiation. If she says that way, very important, you should rule out the medical causes, as well as you have to rule out the other psychosocial history, which is very important. So when you come across the women, the important is you have to have a lot of time for the history and a very proper thorough examination to rule out any physical cause. And then you have to subject them to the laboratory tests, which include the basic hormonal assay, especially the thyroid, as well as the estrogen, and the testosterone level can be assessed to find out whether there is any other problem. And also we have to rule out other causes of the psychological problem, mainly the relationship problem that you should counsel as a partner. So when a couple come with a sexual interest or the desire disorder, the treatment first educate her, counsel her, see what is the cause for this, and counsel her regarding related to that problem. If there is no other problem, then you can give her treatment. So the treatment which is approved by FDA is only one treatment, but there are unapproved treatment in the form of a testosterone therapy, or it could be the tebolone. These are the 2 drugs of choice which are given for the arousal disorders or the desire disorders, which are mainly the hormonal treatment approved. The testosterone is an off-label treatment. The tebolone alone can be given, which is approved in one of few guidelines, societies, but not as a regular one. The non-hormonal treatment, we all know it's a local application of the steroids. If she has a vulval atrophy or a vaginal atrophy, you can give her a local estrogen, which can be a part of the treatment for this conditions. So along with that, a very important role is played by the psychological therapy, which could be a sex therapy, which is a sensate focused therapy, which is the treatment of choice for the problems when they have a hypoactive desire disorder. And the cognitive behavioral therapy is very important. And a couple therapy and the mindfulness technique are the basic treatment choice for this hypoactive disorder. The only mechanical treatment which can be given in the treatment is the Eros clitoral therapy, which increases the vascularity of the clitoris, where you can have this therapy which will improve the blood flow to the genital, and thereby it can produce a better effect on the desire disorder. So the drugs, which is the only drug which is approved by FDA, is the flibanserin, which is a 5-hydroxytryptamine 1A2B agonist and an antagonist. This is the only one which is indicated in a premenopausal women with low desire, and it should be taken every day night, and it also can be used as daily. But the only problem with this, we have to be very careful. If she's a hypertensive, it is not included, and there are a lot of problems with that when they take it regularly. They may have a lot of GI disturbance as well as a psychological headache and pain and discomfort they may have because of this. So it should be given treated in a proper way with patients who don't have a blood pressure or a cardiac problem. It is not advised. Orgasmic disorder, though this has been prevalent up to 40%, but many a times this is not a problem for many women. But of course, nowadays, young women are coming with this orgasmic problem, but this orgasmic problem is less realized by the women because they never think of this orgasmic problem as a problem. But when it is coming to a feminized women, she may think that it is a problem that she should enjoy it. So in that way, these women are mostly on an antidepressants, and they have a lot of problem with the sexual orgasms. The one important thing that we as a gynecologist should know is the sexual pain disorder. That's a vulvovaginal pain or the pelvic pain, which could be a pain due to generalized or localized pain. It should be a lifelong or acquired. It may be even a superficial or idiopathic. So the commonest condition that we should rule out when a woman comes with a sexual pain is then endometriosis in a gynec conditions, and genitourinary could be a urinary infection, or it could be a genitourinary syndrome of menopause, or their dermatological conditions which may cause a dyspareunia, and vulvodynia, which is a condition where this is a persistent pain without any identifiable pathology. And young women, we should rule out a vaginismus, which is a very important condition in a young women they come through when they have an unconsummation of marriage. This part of vaginismus is the important one that I would like to share a few slides about this, because this is the common condition as a practicing gynecologist we come across in a young girl. Either they could come as a marital problem, or they could come as an infertility. When you examine them, they may have vaginismus, which is a very important condition where there's a reflex-like contraction on the circumvaginal musculature, resulting in a non-consummation of the marriage. So vaginismus, it is also known as a vaginal penetration disorder, is an aversion to any form of vaginal penetration. It is actually a phobia of penetration. That's very important. Even they cannot put a tampon, or they cannot even put their finger inside, or they can be scared of any penetration, which is usually a psychological problem. That the main reason may be a lot of sexual abuse, or it could be because of a lot of religious and cultural background from the girl she go through, and a lot of other misinformations and myths and misconceptions, and that leads on to a lot of problem with the vaginal penetration. So this is a very important aspect, because in very many cases the women are even they come out of the marriage and they are not prepared to even live with the husband in a severe forms. And sometimes even if they want to get this corrected, they are not able to do it because of a lot of impact on the vaginal pain, which could be the reason for the vaginismus. So it's a common cause of sexual pain, and it is associated with involuntary tightness of the pelvic floor muscles, what we call as a pelvic floor myalgia. That is what they call us. Its incidence is up to 1 to 7% worldwide. And in the clinical settings, the incidence may be as high as 5 to 17%. And in my patients where we practice both fertility as well as sexual medicine, we have 22% of the women come through this vaginismus. So it is so rampant in a center where we practice sexual medicine. And what are the causes for this vaginismus? the very many research says that the main background be the strict religious and sexual upbringing, as well as the belief that sex is wrong or the penetration causes pain, injury, and bleeding. All these unnecessary talk within the family or with the friends or with the spouse or with the whoever who is talking about the sex, which is very important. And also a history of sexual molestation is a very commonly seen as a cause for this vaginismus problem. And in addition, a fear of pregnancy or childbirth or any sexually transmitted infection. These are the commonest cause that the women have, vaginismus women causing a vaginismus in this women. Is there any organic causes? If there is an organic causes, usually there could be an endometriosis or a PID or a previous surgery or any other radiation or a scarring trauma during the childhood, which could be the reason for this causes. But it should be considered because sometimes it can be associated with other organic causes, which we may have to rule out in the history as well as a proper clinical examination. But in a clear vaginismus, there should not be any organic causes. Everything will be normal, but still the women have a phobia of penetration. So in this way, when you come across any women with vaginismus, you have to grade them. The grade could be grade 1. It could be just a perineal and levator spasm, which can be reassured. You can treat her very comfortably. You can counsel her, reassure her, give her an anesthetizing gel, and ask her to do herself a proper finger penetration. And then you can do that is a milder one. And grade 2 is a little perineal spasm she will get through. And this can be easily corrected by a proper counseling and proper slow pelvic examination. And third is a little severe, where she contracts the levator and lift up the buttocks and then keep it very tight. And even she closes her thighs and will not allow for a pervaginal examination. And grade 4, the women will not do even open her thighs at all. And in severe, it could be the women will have a lot of pain along with crying, screaming, and a lot of, she may even have a sweating, hyperventilation, nausea, and even I've seen women going for a shock when they're even asked to lie down and fold their legs. So this type of a severe is grade 5. So how you're going to manage? The very important thing is the Kegel exercise. Ask them to relax their pelvic floor. Second is the psychotherapy, which needs a counseling, CBT, hypotherapy, hypnotherapy, and even we can have a support groups to help them to say about the positivity and the relaxation, which is very important. And also there can be a physical therapy to stretch the vaginal muscles, which can be aided with the dilators. Along with that, you can give her an anti-anxiety medications, antidepressants, and even a tranquilizers. And also we can ask them to go for a passive vaginal stretching by using the dilators with the low topical anesthetics. And that is the manual dilators, which are the Higa dilators. We can give them and ask them to slowly increase passive stretching, which will help them to relieve the pain. You can ask them to apply a topical topical anesthetics, as well as you can ask them to go for a well lubricated manual slow dilatation, which will improve their fear, which will relieve them for the fear and give them the confidence. And lastly, if it is very severe, we can give them a Botox injection, which can be given as a treatment for vaginismus in a resistant case. So vaginismus, every patient has to be individualized. The treatment should be graded. We should have a series of counseling as a couple, as well as we have to support them. We have to educate them. We have to do a lot of patient training them to go for a manual dilatation. Very important, very slowly, as well as help her to support her, as well as even do a lot of psychological therapy also. One more important thing is the vulvodynia, because this is also we come across a lot of in a gynec practice. That you all know the Frederick's criteria of the diagnostic method, that is the touch method, that is we use the cotton swab test, where the tenderness is just provoked by touching certain points in the vulva, which is which is localized and only seen in women either in the perimenopause or in the postmenopausal. So there won't be any external lesions at all. There will not be any skin changes, but they will have a profuse pain when they are touched and provoked with just a cotton swab. So usually this could be a generalized or a provoked. Generalized, they may have pain everywhere and they will say everywhere it is paining in the vulva. And localized means they will be always have a pain only on a point where it is touched or unprovoked. So that is why we call this as either it could be a generalized or a provoked. The generalized is in the different areas. The touch or pressure may not be prompt, but even with a mild touch, the pain will be very severe, which is in concurrence with the touch or the pressure which we are given. Whereas in a provoked, it will be usually in the vestibule, and patient will always have a pain even for the mildest touch on one point. Usually it is very common in a younger age group, like around 20 or 30, whereas in a generalized, it will be always in the older women. So this is the very important differentiating point in the vulvodynia. So to correct this, we can give them only a proper local anesthetics. That is a very important one. And the gabapentin and the progabapentin are very much useful in such type of a vulvodynia. And sometimes even you can give a Botox injection, which may help them to relieve the pain. Gabapentin is a very important drug, can be used. And also you can give them a local hormonal therapy with the use of estrogen to improve the vascularity and the neurological system of the skin over the vulva, which will help them to relieve of this vulvodynia. So very many times when they come across with a sexual dysfunction, we may have to use even a dilators for even the postmenopausal women to help them to improve in their vaginal stretching, as well as you can even go for a laser therapy, which will improve their vaginal elasticity, which may improve in their penetrative problem and correcting them the pain. So with this verse, I would like to add only one point about the female sexual function index. When a woman comes with a dysfunction, you can put this questionnaire to them, which is a 19-item FSFI, that is a female sexual function index questionnaire, which can give us a multidimensional self-report instrument, which assesses the key dimensions of the sexual function in a woman. There is a score of 6 domains of sexual functions. There's a desire, arousal, lubrication, orgasm, satisfaction, and pain. And they give a total score, and that is the FSFI index scoring system. You can give the questionnaires and ask them to write the questions and scoring. If the score is above the 26, then we call them as a normal. And if there is a it is a cutoff value for this scoring is the 26.5, and if they have it, then we call them as a sexual dysfunction. So this is a very important scoring system which you can use in a clinical practice, which has a series of questionnaires you can just translate in your language and give it to the patient and ask them to fill it up as a couple. And that will give us an idea of what is their sexual function which is being affected and what is its role and how it is being affected as a whole as a sexual dysfunction. So with this, you can diagnose as well as classify them and treat them appropriately in related to the sexual domain which is being affected. So with this word, I would like to thank Komal and her entire team for giving me this opportunity, and I'm open to any questions. Thank you so much, Komal, and thank you one and all. And a thank you, very special thanks to Chairpersons, Dr.Shweta Kumari, Dr. Pradnya, and all the other senior faculties here. Thank you, Komal, and thank you one and all.
It was very wonderful and elaborate talk by Dr. Jeyarani ma'am, and she has very thoroughly covered all the types of female sexual dysfunction. Actually, main point is that even if the patient is having problem, the female doesn't come to the OPD with the problem that I am having this problem. They feel shy in talking about this. So very nicely she has emphasized on the psychosocial history, and mainly it is the counseling part. Most of the patient gets cured with the counseling part only. And the last slide which he has shown that female sexual function index, by this doing the scoring, we can come to know about what type of sexual dysfunction she is having, and accordingly we can treat. So I think she has done justice with the topic, very nicely, very thoroughly covered. Congratulations, Dr. Jeyarani ma'am.
Thank you, Dr. Shweta. Thank you,
Komal ma'am, for giving me this opportunity, and wishing you best of luck for the election. You are really doing putting lot of effort. Almost every day you are doing the webinar. So I think definitely you are going to win. That I can certainly say.
I think on behalf of Komal Madam, I would really like to take this opportunity to thank all our speakers, Dr. Jeyarani Madam, Dr.Punit Bhojani Sir, all our chairpersons for today, Dr. Shweta Kumari, Dr.Yukti Wadhawan, Dr. Madan Kamble Sir, Dr. Shyamal Seth Sir, our panelists for today, Dr.Manisha Jain Madam, Dr.Suchi Jain, and all the others who have participated in today's program. I think both the lectures and the panel, especially by Dr. Richa Sharma Madam, was absolutely extremely informative. Madam, even your talk, I think we all learned so much about female sexual dysfunction. So thank you so much. Komal Madam is with us. If Madam would like to say anything to end this program.
Thank you so much. I think it was just lovely. Everybody spoke so good. Thank you, all of you. Jeyarani, your talk was fabulous. You touched every aspect. Thank you so much. Pradnya, you have done fabulous work. I'm really thankful. She's coordinated it so well. Thank you, Dr. Yukti.
Thank you, Komal. Thank you.
To be there till the very end. Thank you so much.
Thank
Thanks.
you.
Bye,
Thank you,
Dr.
Komal.
Yukti. I can see Yukti with us even on move. So she's a power girl.
Yeah.
More power to
Good
you.
luck, Dr. Komal. Good luck.
Thank you.
Okay, bye.
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 Yeah,
Thank
bye.
you so much, everyone. Thank you. And a special thanks to Shield Connect for coordinating this program as well. So thank you.
Thank you.
Thank you, ma'am.